Okay, well, it's 6:32, so we'll go ahead and get started. I'm sure that some folks are going to continue to file in over the next couple of minutes, but welcome everybody to the West Coast Fellows Conference. It's a real honor today to have Dr. Mark Bilsky with us. And I just want to do a brief introduction. Dr. Bilsky first kind of came onto my radar about 20 years ago when I was doing my medical school and residency in New York and first became interested in neurosurgery and spine surgery. And for some of the fellows now, you maybe don't fully understand where we were in spine onc 20 years ago. But we've kind of just quoted the Patchell study, and so much of the way we thought about the problem was sort of through a surgeon's mindset. And there wasn't a whole lot of real rigorous study at that time. And about 20 years ago, the NOMS criteria first came out and created a framework where we could start to understand these problems in more of an interdisciplinary way, and how radiation could impact what you would do surgically, how you could reduce morbidity. And there was just a huge space to be filled. And Dr. Bilsky and his team played a huge role in filling that space and really changing the field. And obviously, with sick patients that have metastatic cancer, I mean, the clinical implications of that are massive. And beyond doing the actual research, he's been a bit of a prophet and a truth sayer in trying to get the word out. And I think that is so important. And that's really part of the reason I'm so pleased to have him here, so we can platform these ideas a little bit more. On a more personal level, he never trained me or anything like that, but I can basically cold email him with any tough case, and he'll respond to the email in like a day or two, which I think is pretty impressive and kind of remarkable for just a colleague that's trying to help others do well. So thank you, Dr. Bilsky, for being a great colleague and for also sharing some of your time with us this morning.
Honey, thank you so much. Thank you for that really incredibly kind introduction, and for sort of framing, what we're going to talk about today, which I really think, um, you know, the the you guys are in the best training programs in the country for spine, without exception, and the technical side of what we do is going to be extraordinarily straightforward for you. I think what is more complicated sometimes is the decision making, is who and why we do the things that we do. And we've worked really hard, as Hani said, for the last really now 30 years, trying to figure out how to make this meaningful for this extraordinarily vulnerable population that we take care of. And so one of the caveats, I think, from the beginning is you sort of have to put it on the back burner what you know about deformity and degenerative, because in essence, a lot of what we're doing is really focusing on the oncologic issues and the oncologic outcomes. And it just happens to be that spine is that. And so we introduce a lot of oncologic principles. The spine surgery, because you're so good at deformity and degenerative, et cetera, and trauma, is pretty straightforward. But the decision making is a little bit different potentially from what um, you do in these other domains. Metastatic spine tumors are a massive problem in the cancer population, and we've seen an increased number over the past decade or so, partly as an ascertainment issue that MR and FDG have improved detection, but also these newer systemic treatments have improved survival, but are much more effective for visceral than for bone disease. So we think we're actually going to see an uptick in the number of tumors that we're responsible for. And despite this improved survival, the treatment of metastatic disease remains largely palliative. And if we get this kind of outcome of a patient doing this 100-mile paddle on this Whitewater River, having undergone separation surgery for an L3 mechanical radiculopathy, we've clearly done our job in palliation, versus this patient who has both failed fixation and a radiation recall burn. We're trying extension of hardware and a free flap reconstruction. Everything we've done in the past 30 years is to mitigate this kind of virtually unforgivable outcome in this population. I think there have really been three periods that at least I've lived through in the treatment of metastatic spine disease. Up through the 80s, we really had two treatment options: laminectomy without instrumentation and conventional external beam radiation. And laminectomy without instrumentation was obviously a terrible operation for this population, created eye training, instability, deformity, progressive pain, and often neurologic decline. Compared to conventional external beam radiation, which is often given in 30 gray and 10 fractions, a paper as early as 1978 from our institution showed that solid tumors were what they called unfavorable responders, or what we now call radioresistant. And despite these poor outcomes, conventional radiation was as effective as decompressive laminectomy. And when I started at Memorial, it was really standard of care. By the 1990s, surgery got infinitely better. We had the development of segmental instrumentation, transarterial embolization described by Sonny Sandrazen in 1990 for hypervascular tumors, and then the Patchel study 2005 showed that surgery was better than conventional external beam radiation for solid tumor malignancies. And we began to see this proliferation of incredibly aggressive approaches for metastatic disease, including en bloc spondylectomy. And these procedures were largely not well tolerated by this patient population. But in that period of time, the decision-making algorithms were largely surgically based, such as the Tamita and Takahashi score. By 2010, we had the development, evolution, and integration of transformative technology in the form of stereotactic radiosurgery. It's defined as high-dose perfection conformal photon beam delivery, often given as 16 to 24 gray single fraction, one dose of radiation, or 24 to 30 gray in three fractions. And compared to that conventional external beam radiation, the responses are both histology independent and ablative. Essentially, there is no radio resistance. And that fundamentally changed everything for us, including the indications for and type of surgery that we do. With the integration of radiosurgery, the decision-making was mandated to become multimodality. At Memorial, we use the NOMS decision framework, where radiosurgery currently is the most important for tumor control, and surgery now is largely an adjuvant to radiosurgery for decompression and stabilization. In the NOMS framework, there are four sentinel decision points: neurologic, oncologic, mechanical stability, and systemic disease to decide best treatment. It's an algorithm at any point in time, but we largely leave it as a decision framework so that we can integrate evidence-based medicine and new technologies as they become available. And what NOMS allows you to do is take this incredibly complicated patient population. This is a good example of what you see in your emergency room. A 7-year-old has papillary cancer, BRAF positive, got thyroidectomy and solumetinib, developed metastatic disease that initially started with biologic back pain. That's that night or morning pain that gets better over the course of the day and simply represents tumor being there. And then it became mechanical. He developed severe axial load and recumbency pain. He's neurologically normal, and then he's got all these other medical issues and all this systemic disease. And then you look at his x-ray and he's got high-grade cord compression with a plane and burst fracture and bilateral posterior element. And the question is, when you look at all of this data, there's all this noise in this patient, what's actually important in trying to make a decision? And with NOMS, you can break it down into four very simple components that you can pull out on any patient and make consistent decisions. And that's largely what we're going to talk about today. In this case, the patient's neurologically normal but high grade. Papillary thyroid's resistant to conventional external beam radiation, which is the only radiation you can use in the setting of high grade cord compression. Instability, he's grossly unstable, a SIN score of 14. And then we do a systemic assessment, like what makes sense in the context of the disease. You know, we know that he probably needs surgery based on the NOM, but can he actually tolerate surgery? Is he going to survive long enough to benefit? And ultimately, in this patient, hybrid therapy, which is now defined as separation surgery followed by radiosurgery, and we'll talk about how we got there. In the NOMS decision framework, the neurologic and oncologic considerations are made in combination. So from a neurologic perspective, we're very concerned about whether the patient has myelopathy and functional radiculopathy, but much of the decision-making is based on the degree of epidural spinal cord compression. And there's a scoring system that's been validated where 0 is bone only, 1A, B, and C are different degrees of epidural impingement without spinal cord compression. 2 is spinal cord compression but CSF seen. 3 spinal cord compression, no CSF seen. And for decision-making purposes, the 2s and 3s are considered to be high-grade cord compression. From an oncologic perspective, what we're really talking about is how we achieve local tumor control. And to us, it's completely predicated not on how much tumor you take out, but on the radiation response. And radiosensitivity, again, has been completely redefined as we transition from conventional external beam radiation to radiosurgery. Now, there are radiosensitive tumors to that conventional radiation, that point and shoot radiation, 30 gray and 10 fractions. The hematologic malignancies, lymphoma, myeloma, and then the hormone-driven solid tumor malignancies, breast and prostate. The remainder of the solid tumors are largely radioresistant to conventional radiation with median durable responses of only 3 months. Here's a patient with multiple myeloma, an exquisitely radiosensitive tumor, has 3-level high-grade cord compression. We put the patient on high-dose steroids, gave 30 gray and 10 fractions, and you can see the 10-day follow-up film, the tumor completely apoptosed, decompressing the spinal cord, and in this case, recovering the patient from an ASIA-C to normal neurologic function. Breast and prostate, similarly, we are very comfortable treating high-grade cord compression with conventional external beam radiation. The difference between that and myeloma and lymphoma is if they have high-grade cord compression and they're myelopathic, you won't see that apoptotic decompression. It takes months for that tumor to involute in the epidural space. And so if we have high-grade cord compression, prostate will often go to conventional radiation. If we have breast prostate with myelopathy, they go to surgery because we don't think we can decompress them quickly enough with radiation to get recovery of function. There's still a role for conventional external beam radiation, but for radio-resistant tumors, conventional radiation, those solid tumors with minimal or no spinal cord compression, we typically go straight to stereotactic radiosurgery. There's now class 1 evidence that radiosurgery is better than conventional external beam radiation in terms of pain and durable control. Here's our series of a little over 800 patients who got treated with radio-resistant tumor histologies where we had that definitive target for radiation with ESCC scores 0 to 1C, so no spinal cord compression. There were 2 dose cohorts. The median dose of planning target volume in the low dose cohort was 16.4 gray in 1 fraction. In the high dose cohort, it was 22.4 gray single fraction. The only factor of significance in the in silico failure was a dose of radiation, but even in the low dose cohort, at a year, we only had a 5% failure rate. Remember, compared to conventional external beam radiation in the same cohort was a 70% failure rate. At 4 years, it increased to 20%. In the high dose cohort, at a year, we have less than a 1% chance of recurrence, increasing to 2.1% at 4 years. We overcome this radio resistance with high dose perfraction radiation, and these responses become both histology and volume independent. Now, much of the past, really now 20 years, has been used to define dose constraints for organs at risk, because all of those tissues around there can't take that 24 gray number that we like to give these patients. The biggest constraint and the biggest toxicity that we're concerned about is obviously to the spinal cord. And in single fraction radiation, the cord D max that you can give to a point dose on the cord is only 14 gray. And remember, our ablative dose is somewhere around 22 gray. So, and that's the reason really that we don't treat high-grade cord compression with radiosurgery without a decompression, really for 2 reasons, right? One, if we give that ablative dose at the margin of the cord, we're going to risk creating radiation myelitis. But if we underdose at the margin of the cord, we risk epidural progression where we need the greatest tumor control. That being said, we now have a very large series of not the single fraction, but hypofractionated radiation with high-grade cord compression in the absence of myelopathy, and we're getting about 80% 2-year local control. So over time, you'll start to see this paradigm shift a little bit, but it's going to take a lot of work to convince radiation oncologists that they can treat high-grade cord compression with radio-resistant disease. And for that reason, patients with radio-resistant tumors, solid tumor malignancies, with high-grade cord compression, with or without myelopathy, will often go to surgery followed by radiosurgery. And as alluded to by Hani, this is largely predicated on the Patchell study, which you all know well. It's a prospective randomized trial, solid tumors with myelopathy, but the myelopathy could simply have been that biologic back pain, comparing surgery and conventional external beam radiation to conventional external beam radiation alone. And in every outcome variable, surgery was better than radiation. And based on that and a number of other studies, the Spinal Oncology Study Group made a strong recommendation that patients with high-grade cord compression due to solid tumor malignancy undergo surgical decompression stabilization followed by radiation therapy. The question, right, became what kind of surgery and what kind of radiation. With the integration of radiosurgery as a post-operative adjuvant, the surgical goals, right, a spinal cord decompression for neurologic salvage, and using screw rod systems to provide mechanical stability remain the same. What changed, right, is the oncology. How we achieve local tumor control is completely predicated on the radiation response. So when we use conventional external beam radiation as a post-operative adjuvant, it made sense to do maximally cytoreductive surgery, either gross total resection or en bloc. With the integration of radiosurgery as a post-operative adjuvant, maybe the only goal, right, has to be to reconstitute the thecal sac to create a better target for radiation. And that became known as separation surgery. Here, an 86-year-old 86-year-old female with papillary thyroid cancer, Asia C, has 3-level vertebral body and extremely high-grade cord compression. And I would submit to you that there is no way to get this patient through a 3-level front back surgery. In separation surgery, the technique is fairly simple, right? Traditionally, we instrumented 2 levels above and below the index level. We take a high-speed drill, 3 millimeter matchstick, and we drill off the lamina, superior and inferior facet joint, and pedicle flush the vertebral body, essentially to account for where our epidural disease is. We find normal dural margins and strip the tumor off with the dura, and then the key component of this is to strip the posterior longitudinal ligament across the anterior dura to affect a margin in that plane. And from a very simple posterior approach, you can do a very effective circumferential decompression. The goal of separation surgery, again, is not to take out all the tumor, but simply to reconstitute the thecal sac to create a better target for radiation. Why do we like separation surgery in metastatic disease? They're very short operating times, 2.5 hours. We can do an emergency operation for epidural tumor in the middle of the night without the need for an anterior access surgeon or the incumbent morbidity associated with anterior approaches. And we can do these large multi-compartmental tumors where our only real obligation is to resect tumor within this blue circle to reconstitute the thecal sac to create that better target for radiation. And also, you're going to do a better and safer epidural decompression. Why? Because we always know where the spinal cord is. We're coming from this posterior approach, and we're always stripping tumor away from known dura and pushing the tumor away from the spinal cord. If you come in from an anterior approach through this tumor, you pray that you find the dura before you're in it. From posterior, we always know where the normal dura is, and we can always strip tumor from normal dural planes. In terms of approach morbidity, there's approach morbidity anterior at every level, especially in cancer patients where they've often had prior radiation or prior surgeries, and you're trying to mobilize these critical structures off of the spine just to get there. One of the harder areas to get to is C12. This was a 45-year-old, had a low-grade conus primary tumor. The best approach in tumor is a transmandibular osteotomy, and so we split the jaw and came through to resect this tumor. And the problem in the metastatic population is that just from the approach alone, they have to be pegged and trached, for a minimum of 2 weeks after that surgery. In this case, it was in vogue to put an anterior cage in to try to get graft here. And in reality, all of the load at C12 comes to the posterior elements, and we got a really good bone fusion in the back. At 7 years, we were looking at it through the mouth at the cage and had to go back and do a formal pharyngeal reconstruction. Again, a terrible complication in a primary tumor, but in the metastatic population, way too much morbidity, way too much surgery for this patient. That's in counter-distinction to this patient, 33-year-old female who had multiple fibroids resected. She was 3 months pregnant and tripped on an airplane jetway and became acutely quadriplegic from this massive tumor at C12. There was no way we were going to take her for transmandibular osteotomy, and so we simply did this separation surgery, right? We just reconstituted the thecal sac and did occipital-cervical fixation. And by the grace of God, she went from being acutely quadriplegic to neurologically normal at 2 months, and it was really because she was young and healthy otherwise. The tumor ended up being a low-grade uterine myosarcoma, which is incredibly unusual to metastasize. We ended up giving adjuvant radiation using photon-based IGRT, 66 gray and 33 treatments. Today, if we treated this, we would either give photon-based IGRT or proton beam 30 gray in 3 fractions. The baby was born 4 months after the injury, but this was a tumor that we left behind after separation surgery that got her neurologic recovery. Here's our 15-year follow-up film. It's not about the amount of tumor you take out. It's about the response to radiation that gets you durable tumor control. Here's a 54-year-old female, high cervical myelopathy. This was needle biopsied. We knew this was a chordoma. It's unresectable for cure with an en bloc for wide marginal resection based on a high-grade epidural disease and bilateral vertebral artery involvement, and then this large parapharyngeal mass. We did simple separation surgery and left all of that tumor on the vertebral arteries and in the peripharyngeal mass. Patient got recovery of neurologic function. Here's a 7-year follow-up film after 24 gray single fraction with no evidence of residual recurrent tumor. Changes to separation surgery. Traditionally, we went long segment fixation, minimum 2 levels above and below the index level. In part, it was to distribute load and osteoporotic bone, and in part, it was because when patients progressed tumor, it was often an adjacent segment. And if you had all of your instrumentation 1 level above or below, there was a pretty good chance you were going to fail fixation at some point. And we did well with long segment fixation. Our fixation failure rate in this population was only 2.8%. More recently, now it's been 5 years, we switched to short segments, so single level above and below with cement augmented fenestrated pedicle screws. And our fixation failure rate in our first 44 patients was 2.2%. In our next 500 patients, it went to about 3.6%. So it's a very effective strategy, short segment fixation with cement augmentation in this patient population. And now we're starting to incorporate some of the minimally invasive decompressive techniques, although because of bleeding issues and such with a lot of these tumors, it may not be comfortable unless you're super talented with minimally invasive. My partners do this incredibly well, and I'm probably a work in evolution with this, but I think this is absolutely coming into the domain of, um, of spine tumor resection for metastatic disease. P carbon fiber screws have become a real thing in spine tumor reconstruction, and they are useful, they are meaningful, but they are incredibly expensive, and so you have to sort of choose that battle as you see fit. But there are definite benefits to it. One is that it's much easier to image for recurrence compared to titanium. And then realistically, when we give photon-based SBRT, there's no real issues with delivery using titanium. There's about a 3% shielding on the radiation, but they can overcome that with newer techniques such as volumetric arc therapy. So in terms of the delivery, there may not be a great benefit. But the problem with titanium in the post-op setting is we often have to do mylo-CT for the simulation film, so you have to put a patient through a myelogram. And with P carbon fiber, you can probably do an MRCT simulation. The biggest benefit is you really can't give effective radiation if you're going to do post-op protons or carbon ions. And so many centers, it's really, I think for the surgeon, you can use titanium or PEEK. They're very similar. The durability of the construct is similar. But it's really your radiation oncologist who dictates what they need to be able to deliver the radiation that really drives, in large part, that decision, at least in our institution. Many of you are really vested in deformity and trauma and degen. And the one thing I will tell you in the titanium hardware is there are some construct limitations that really do cause problems for us, either in imaging or in radiation delivery. And this was a patient treated outside who had a 2-level fracture that actually ended up being myeloma, which potentially could have been treated biopsy and kypho, and for a number of reasons, they had Parkinson's, et cetera. They ended up with a T10 of the pelvis fusion, and solved the pain for a good period of time, and then there were some other issues. What I want to show you, though, is you can't use your deformity correction stuff in tumor if you're going to put this kind of artifact across the canal, because we cannot follow them for recurrence, and we cannot effectively give them radiation. The big bugaboos is if you're going to use a dual rod construct, put your dual rod outside of the instrumentation and not across the canal. Don't use cross connectors across the area. And then the big problem we have are these titanium expandables. It's really the ring that puts a huge amount of artifact across the canal. So you really want to temper the constructs that you use based on the fact that you have to image for recurrence, and then you have to be able to give radiation effectively in this patient population. In terms of separation surgery, how do we actually do in terms of outcomes? In terms of performance status, 75% of our patients recovered ambulation, and overall 90% are ambulatory. In terms of patient-reported outcomes, patients do significantly well in terms of pain right now and general activity. In terms of local tumor control, which in this population, now that they're living longer with these biologic checkpoint inhibitors, is really important. If you did this really aggressive surgery, right, intralesional gross total front back en bloc followed by conventional external beam radiation. The local control was only 30% at a year, and the biggest predictor of recurrence, again, was this tumor histology. So again, you can be as aggressive as you want with a surgery, but you cannot overcome bad biology or aggressive tumor biology with a more aggressive resection. The aggressiveness of the tumor is going to dictate the recurrence and not how much tumor you take out. With separation surgery, this is our initial series of separation surgery followed by radiosurgery in 186 patients. Most were operated for high-grade cord compression with radioresistant tumor histologies. 50% had already failed prior radiation therapy. There were three-dose strategies: high-dose single fraction, high-dose hypofractionated, and low-dose hypofractionated. The one-year cumulative recurrence was 16%, but if we gave a high enough dose single or high-dose hypofractionated radiation, we had less than 10% recurrence at a year. Again, we overcome radioresistance with high-dose per fraction radiation, and these responses uh, uh, are, uh, um, are histology independent. If we look at we more recently looked at histology-specific progression-free survival using this concept of separation surgery followed by radiosurgery. For renal cell carcinoma, our 2-year progression-free survival was 92%, non-small cell lung cancer 95%, and colon cancer 87%. We looked at mutation status, and the patient had an EGFR mutation, was treatment naive. There was a 50% improved overall survival. And so again, this is compared to if you did aggressive surgery followed by conventional external beam radiation, you had a 30% 1-year local control. And now with this minimal surgery followed by radiosurgery, we're upwards of 90% in that same population with significantly less morbidity. One thing I do want to cover, I'm not sure if we're really short on time, I apologize, is that patient who comes into the emergency room with unknown tumor histology. So you don't know what the tumor is, and they come in severely myelopathic. This is a 53-year-old presented Asia C, 3 out of 5 middle extremities with no preceding history cancer that ends up in your emergency room. And there are 3 possibilities. It's either going to be solid tumor. It could potentially be a hematologic malignancy, such as lymphoma or myeloma, where the decision is probably going to be to use conventional external beam radiation, or potentially chordoma, where the recommendation is en bloc for marginal wide resection. My philosophy now, and it has changed over the year, is just take them to surgery. It doesn't matter what the tumor histology ends up being. If it's solid tumor, we've justified why you would take them to surgery for that. For hematologic malignancies, the problem is you needle biopsy, you get a small blue cell tumor, but it may take 3 or 4 or 5 days to get that permanent histology back. And while you're waiting to get them to treatment, waiting for that diagnosis to come back, they will often fall off the cliff. It doesn't take a lot of incremental growth, even on high-dose steroids, to pitch them over the cliff, and they'll go from an Asia C to an Asia A to paralyzed while you're waiting for that diagnosis, and you're sitting on them. And our recommendation is don't wait for that tumor histology to come back to show you that it's radiosensitive. Get them out of trouble, and then we'll get them to effective therapy. And then for chordoma, high-grade cord compression, as we've shown you before, precludes an en bloc wide resection, a curative resection, and we can salvage them with radiation. And in this case, the patient actually ended up having a chordoma. They were taken in an outside hospital for this simple separation surgery that got them neurologic recovery with a standard reconstruction in the metastatic population. We like to give 24 gray single fraction radiation, and we did not have enough room to do that, so we took them back for a redecompression. And then this is a very good strategy instrumentation in the metastatic population, but it's not going to be durable in somebody who's going to live hopefully many, many years. And so we went back and reconstructed with cement augmented screws a dual rod construct, again with those rods outside the canal. And then we did a vascularized rib graft and rotated over posterior lateral. We gave 24 gray single fraction. Here's a 4-year follow-up with no evidence of residual recurrent tumor on standard MR or DCE imaging. And in our series of chordoma, we looked at patients who got irradiated 24 gray single fraction in the mobile spine and sacrum. If we had a definitive target for radiation, we actually just do definitive radiation now. We actually don't take out the tumor. It wasn't really intended that way. We really intended to use it as neoadjuvant followed by resection. But it turned out those patients never progressed to needed surgery, and so we have just followed those. What I don't want you to get hung up on, the ivory towers are telling you that if you have high-grade cord compression and bilateral vertebral artery involvement, you need to take those patients for an en bloc resection. And what I'm going to tell you is you can salvage those patients with radiation more effectively than trying to do a surgery that has no hope of giving them cure. And in our series of mobile spine with high-grade cord compression, we use curettage gross total initially and then transition to separation surgery. And if we gave 24 gray single fraction, our 5-year local recurrence-free survival in that population was 90%, which is significantly better than you're going to do with an attempted en bloc, and there's no benefit to en bloc followed by radiosurgery. So start to think about how to integrate radiosurgery into the chordoma paradigm. MD Anderson uses the same paradigm we do. They gave 24 gray single fraction as definitive radiation and came up with exactly the same number we did at 5-year local control, 90%. And then if you're vested in protons or carbon ions postoperatively, I think this is a really compelling series of patients at initial therapy underwent en bloc resection. At first recurrence, they underwent just curettage intralesional resection followed by proton beam, and there was no difference in local tumor control. So radiation, chordoma has been considered to be incredibly radioresistant. It turns out the high dose per fraction radiation, greater than 70 gray BED, they're incredibly radiosensitive, and you need to begin to think about how to integrate that into your chordoma management. Just quickly, we did the NO assessment. Mechanical instability is a separate assessment, right? Because no amount of radiation will stabilize an unstable spine. The SINS criteria was developed to define instability in a neoplastic setting. All of these are weighted by their contribution to instability, with 0 to 6 being stable, 7 to 12 potentially unstable, and greater than 13 unstable. For those patients with painful burst and compression fractures in the thoracic and lumbar spine, they're very good candidates for standalone kyphovertebroplasty, and there is class 1 evidence that kyphoplasty is better than best medical management at a month durable out to a year. And we use this fairly liberally. We do about 400 of these a year in our center. If you have a burst or compression fracture with posterior element disease, you can't do a standalone kyphoplasty. You have to give them a posterior tension band. We now do this with percutaneous pedicle screws that we cement augment with a vertebral kyphoplasty at the index level. And again, in this population, we went from significant pain to moderate none in the vast majority of patients. And then there are these patients, such as this with a C1-2 fracture subluxation, where you can't do a percutaneous procedure and they still need open procedures for stabilization. More and more, we're trying to get away from surgical procedures anytime we can. We see a lot of C1 lateral mass fractures. They get neck pain for a couple of days, but they're defined by occipital neuralgia, the C2 nerve root compression. We used to take them for occipitocervical fixation, and now we just do a nerve ablation of the C2 nerve root, and 80% of those patients will avoid surgery. Sacral insufficiency fractures are a terrible problem in the cancer population because those patients are bedbound. They can't even roll over in bed. We've tried sacroplasty. It was about 50% effective. Instrumented fusion is a failed model because most of these patients are osteoporotic. And then our pain person came in and said, I can fix this. And now we just do clinial nerve and L5-S3 lateral branch ablations. And the vast majority of those patients can get up and move the next day without fixing the fracture. We just denervate the sacrum. And it's been an ungodly successful strategy for that patient population. Many of you are interested in deformity. We only are interested in deformity if it defines the problem that they have. Most of these patients are more concerned about their oncologic issues and walking than their sagittal balance. We see a number of patients who get irradiated for head and neck cancer, and they end up with this fibrosed sternocleidomastoid with chin-on-chest deformity, where they can't have horizontal gaze, and they're just miserable in life. And we talked to this patient for a long time because essentially the fixation for this is cervicothoracic, occipitocervicothoracic, and we've essentially put him in a functional halo for life. He's the happiest patient that I have. We got him back horizontal gaze. If you're going to do this with sternocleidomastoid, the way you release this fibrosis is we just put Botox into the sternocleidomastoid, and then we can reduce them back into horizontal position and then fix them. And the last assessment, right, is you make this NOM assessment. The last question you have to ask is, what are the systemic disease and medical comorbidities that impact your ability to do this? What makes sense in the context of their disease? Survival is often used as a predicate to determine whether patients should undergo surgery or even radiation therapy. With chemotherapy, we knew almost to the day how long people would survive. And now all of a sudden, we've entered this new era of systemic therapy with biologic and checkpoint inhibitors. Here for melanoma, a single checkpoint inhibitor more than tripled survival compared to standard chemotherapy. And so we had to begin to factor that into our decision making. And fortunately, the Harvard institutions have come up with predictive models of survival that were determined in the era of biologic checkpoint inhibitors, the sorganomogram and the New England spine score. So if you look at somebody just from a cancer standpoint that you're thinking about going to surgery, it's not bad to plug in numbers and see if they're going to be a 2-month survivor or potentially a 1-year survivor to help you make a decision about whether it's worth it for them to go through that. The other assessment you have to make is medical. Remember, if you're doing deformity degenerative, they're going to have a whole workup. A lot of these people are coming in with emergencies and they're going to be COPDers, et cetera. So you have to factor in the medical and whether they can actually tolerate what you propose. So in the GNOMES framework, as it stands today, for radiosensitive tumors, that myeloma, lymphoma, breast, and prostate, regardless of the degree of cord compression, we still use a lot of conventional radiation. The exception is breast, prostate with myelopathy. We're going to take those patients to surgery. For radio-resistant tumors, where we have a definitive target, we go straight to radiosurgery. And for radio-resistant tumors with high-grade cord compression, with or without myelopathy, we go to separation surgery followed by radiosurgery. If they're unstable, it's a separate assessment, typically based on the SINS criteria, and often they're candidates for kyphovertebroplasty, PERC screws, or open surgery. And then everything is predicated on what they can tolerate from a systemic standpoint. And hopefully we've made it clear. You take this really, really, really complicated patient and just plug it into your GNOMES framework, and at least it gets you organized in how to think about all of these competing variables that come into play when you make decisions about these patients. It's a cornerstone. GNOMES is a cornerstone of comprehensive coordinated care and the modern management of spine tumors. What it allows you to do is make very consistent, timely, evidence-based decisions, and then for us to integrate and develop meaningful technologies. Um, if you're interested in academics in spine, there is still an inordinate amount of stuff that we are working on to make this better. And we would, bringing in people from a lot of different domains helps progress and promote best care for these patients. And if anybody's interested, we would be so happy to talk to you and plug you into any of these um, uh, uh, research initiatives. And with that, I thank you so much for your time.
Thank you so much, Dr. Bilsky. I know it's a really big topic to try to do, and 30 minutes are just over, and you did a very nice job with it. So we have a few minutes here before folks have to run to the OR. So if I could just open up the field for questions, if you have a few more minutes, Mark.
Thanks so much, for sure.
Any questions from the audience?
Hey, Mark, it's Greg Mundis. Does someone else have something?
What's
No,
that?
go for it, Greg.
Oh, so, not all surgeons are created equal, and there's definitely surgeons out there that are just like crazy talented and gifted, and then there's the rest of us. And then is that the same with radiosurgery? Like, is that more of a science, or do you feel that the folks doing the radiosurgery are there people that are just like overly talented in that realm? And is that translatable to the masses, or is that not true?
Great question.
Yeah, it is a great question. I think radiosurgery in the body and spine is a very late evolution. Because they had been treating with conventional radiation for so long, and so many people were used to that. There were 5 or 6 centers that started radiosurgery early on, and when we started, there were almost no parameters defined. We didn't know doses. We didn't know ablative doses. We didn't know dose constraints for organs at risk. And so what essentially happened over the last 10 or so years is the major centers have defined those parameters, and then it's much easier with data on toxicity, et cetera, to begin um, to send that out to anybody who wants to do it. And so I think a lot of it was early on. Yeah, not a lot of people would do it. They wouldn't do it at the doses that we were treating to. there was some controversy about our dose versus other camps where they use more hypofractionated radiation. But I think now there's so much data on outcomes that people will get more comfortable. A lot of what we do in a cancer center is we find problems that we can't solve with surgery, or, somebody's too old, too sick for radiation, but they have high-grade cord compression. And so what we had was an incredibly brilliant radiosurgery, Josh Amata, who's sort of the father of this, and then Dan Higginson and Adam Schmidt, who, were doing this every day. And so they wouldn't do single fraction for that, but you improve the therapeutic window. You're going to take a little less tumor control, but better, but a little less tumor control, but much less toxicity if you hypofractionate, right? So we then looked at a big series of those patients who had high grade that were not surgical candidates, where we did 8 to 10 times 3, and then put those numbers out. And then you begin to disseminate that. So technically, it's not like being a technically brilliant surgeon. It's a matter of looking at the data and saying, I can do that in my institution. And, again, if you're my age as a radiation oncologist, it's very hard to adopt this, because you're so used to doing the other. But the people who are coming out now, there's not a single disease site that's not using IMRT or photon-based hypofractionation. So they're going to be much more comfortable. And ultimately, every city will have somebody who is interested in spine radiosurgery and knows how to do it. So yeah, I think it was more a matter of defining, disseminating, that it was. I don't want to say talent, because I think Josh Yamada is a genius and pushes field as hard as anybody to make it safe and better for these patients. But eventually the goal, like separation surgery, is not that it's proprietary, right? It needs to be done in every institution well, so that we treat these cancer patients as well as possible. Does that make sense?
Yeah, it does.
That adoption. Well, it's 7:14, so Dr. Bilsky, we're going to let you go. But thanks everyone for signing on, and obviously this will be up on our website, so hopefully a lot of other folks can learn from it and watch it, and keep spreading the word.
Yeah, Brian.
Thanks, Mark.
So much.
Thank you so
Appreciate
much.
you.
Have a great day, everyone.
Yeah.